In this video, we're going to discuss how to interpret a wireless Bravo pH capsule study like this. Now, there's a lot of useful data collected during these studies beyond simply answering the question, is acid reflux present or not? And as we'll see, we can specifically tailor our treatments to the specific kind of acid reflux seen. But before we jump into how to interpret a Bravo, we need a little bit of background information. Now, we know that symptoms of acid reflux have continually been described as unreliable for diagnosing acid reflux. In 2005, the FDA approved the Bravo monitoring system for the following indications.
Evaluation of patients with symptoms of GERD, but normal upper endoscopy. So in these patients, the question really is, are the symptoms they're having actually acid reflux at all, since we have no endoscopic evidence to support this? Patients with typical GERD symptoms who fail empiric PPI therapy. This is answering the question of, is this actually GERD that's refractory to PPI therapy, or is it not acid reflux at all? Patients with atypical symptoms of GERD who fail empiric PPI therapy. Atypical symptoms such as chronic cough, globus sensation, or laryngopharyngeal reflux. Also, patients considered for endoscopic or surgical reflux therapy, an alternative for patients who can't tolerate catheter-based monitoring.
Now, the question of whether or not to do a Bravo study on or off PPI frequently arises. By the time we get to the point of doing a pH study, most patients will have already been on or are currently still on an empiric trial of PPIs. The main question that Bravo helps us answer is whether or not there's pathological acid reflux. Now, imagine for a second that we have two patients.
One does not have GERD, and he's a healthy control that we've empirically placed on a trial of PPIs. The other patient does have GERD, but it's well controlled on PPI therapy. So how would we be able to distinguish these two patients on a Bravo study? The answer is, we probably couldn't if the PPI is adequately treating the patient with reflux. Since we can't tell these two groups apart on Bravo, we don't want to keep patients on medications without a clear therapeutic benefit. So, Bravo testing should generally be done off PPIs if the diagnosis of GERD has not been established. PPI should be stopped 1 to 2 weeks prior to the study, and H2 blockers for at least 3 days prior to the study. We can conceptualize this by categorizing patients into two categories: those with an established diagnosis of GERD and those with the diagnosis in question. Most of the patients will fall into the latter. Now, on the left-hand side of this diagram is the diagnosis of GERD is in question. And these should be done off PPI therapy. This will answer the question, does pathological acid reflux exist? Now, on the right-hand side of this diagram are patients with an established diagnosis of GERD. LA grade C or D esophagitis, Barrett's esophagus, peptic stricture seen on prior endoscopy, or a prior Bravo test that was positive for acid reflux disease is all diagnostic for reflux, in which case we're not answering the question, does reflux exist? We're answering the question of, is GERD unresponsive to PPI therapy? Contraindications to Bravo are bleeding diathesis, esophageal strictures, severe esophagitis, esophageal varices, or bowel obstruction, such as patients with Crohn's disease that may have small bowel strictures that prevents passage of the device. It's also contraindicated in patients with pacemakers or implantable cardiac defibrillators, as the device signal may interfere with signal transmission. The capsule contains a small magnet, and patients therefore should be aware that they should not have an MRI within 30 days of undergoing Bravo placement.
Now that we have some background information, let's start analyzing the study.
Before we start looking at individual days of reflux, we want to first get an overview of the study and ensure the study was good quality and develop a preliminary diagnosis. We can do this by looking at the first page of the study, which gives us a pH tracing of the entire study, as well as data points and parameters for the duration of the study. The esophagus normally has a pH of around 7. When the pH of the esophagus drops below 4, mucosal damage can occur. So for this reason, this line right here is drawn at a threshold of 4. Anytime that the pH probe detects a pH of less than 4 for at least 30 seconds, and some manufacturers say 10 seconds, it will highlight an area in red. On this study, we can see multiple spikes of transient reflux episodes. We can also see if these reflux episodes tend to occur while the patient is upright or supine. So up here at the top, we can see that this blue line represents patient being supine. So over the duration of this study, this probably represents 3 nights that the patient went to sleep. And we can briefly look and see if reflux episodes tend to occur while the patient is supine or is upright. And in this case, Most of the spikes appear to be here during the daytime while the patient is not supine. We see one isolated episode here, but the majority of the reflux episodes look like they tend to be while the patient is not supine. We can also see if these reflux episodes are related to when the patient has a meal, indicated in green here. So all of these green boxes are indicative that the patient reported that they were eating. The gray boxes here indicate anytime the patient pushes the button to report symptoms. And we can also see anytime the patient reports that they took a medication, indicated here with the pink boxes. So to get a preliminary diagnosis, we can see multiple spikes of acid reflux that don't appear to be related to supination, don't appear to be related to food, and appear to be well correlated with the symptoms that the patient is reporting. For an even better assessment, we can correlate the timing of these reflux episodes with the diary that the patient provides to see exactly what the patient was doing at this time.
Now, we have to keep in mind that everybody experiences reflux episodes, and the presence of reflux episodes on a Bravo study does not necessarily mean pathological acid reflux. For this, we need to look at additional data points.
We can also see on the first page data indicating the acid exposure summary, which has been further broken down into acid exposure time, longest reflux episode, and the DeMeester score. We also see data regarding the correlation between reflux episodes and symptoms, such as the Symptom Index and the Symptom Association probability. So what do these data points actually mean, and how can we use them to develop a diagnosis? Well, the acid exposure time is the time that the pH is less than 4. This parameter is particularly useful, as it has been shown to best correlate with endoscopic damage. As previously mentioned, everyone experiences acid reflux, so the presence of reflux episodes is not necessarily pathologic unless it reaches a certain threshold. Now that threshold for this study is 4.9. It's important to note that other devices may use slightly different values for various parameters. For example, some manufacturers use a cutoff for acid exposure time of 4.4% rather than the 4.9% referenced in this study. Now this variation is based off the device manufacturer, as well as different reference studies for what constitutes a normal amount of acid exposure. So just to briefly show you, this was a paper looking at various studies across a pretty wide time period for different things that we measure for acid exposure. So if we look at the percentage of time less than 4, for example, we see different studies from different time periods indicating slightly different numbers, anywhere ranging from 3.7% all the way up to 5.8%. And this data is all for the 95th percentile. So when interpreting your studies, be sure to reference your device's specific threshold for what is considered normal. We can see acid exposure time further broken down by upright and supine times with corresponding normal values. Now, why is knowing this important? Well, if reflux events are predominantly supine, for example, we can recommend targeted interventions for this kind of acid reflux. The DeMeester score is a composite score weighing each of these 6 parameters to give a single value, with less than 14.72 being considered normal, with a higher number potentially indicating pathological acid reflux. DeMeester was a surgeon, and the DeMeester score is commonly used in the surgical literature. While it may be somewhat useful, it's a little bit of an oversimplification if we just look at it in isolation. It's also important to keep in mind that the DeMeester score does not take into account artifacts or symptom reflux association. Now let's look at the parameters that detail symptom association. Here we can see the number of occurrences that the patient pushed the button on the receiver for various symptoms. So this patient, for example, pushed the button for regurgitation 20 times and belching 15 times. The symptom index is simply the number of times that the patient pushed the button, indicating symptoms when the pH was less than 4. So in this case, for example, out of the 20 times the patient pushed the button for reflux, 9 of those times had a pH of less than 4. 9 divided by 20 is 45%. A symptom index of greater than 50% is considered positive. We can think about this as the true positives divided by the number of times the patient pushes the button. The shortcoming of the symptom index is that it does not take into account the total number of reflux episodes. So if a patient had, let's say, 1 reflux episode and pushed the button during this episode, the SI would be 100%. And with such a small n, it would be very difficult to establish a strong correlation. So to get around this shortcoming, the Symptom Association probability was developed. The SAP is a much more complex calculation, and it answers the question, what is the likelihood that the patient's symptoms are related to reflux? A Fisher's exact test is used to compare symptoms versus reflux episodes to give a probability for determining if there's a true correlation between symptoms and reflux episodes. In other words, we can think of this as similar to a p-value. And in fact, just like a p-value where the cutoff for statistical significance is less than 0.05, indicating a less than 5% chance that findings are due to chance, we use this same cutoff, but we represent it a little bit differently. A Fisher's exact test does in fact produce a p-value, and the SAP is just 1 minus the p-value times 100. So it effectively means the same thing as a p-value, but we just represent it a little bit differently. So our cutoff for significance for the SAP is greater than or equal to 95%, which indicates that there's a greater than 95% probability that the symptom to reflux association is a true correlation and not caused just by chance. Both the SI and the SAP can be useful, but neither has demonstrated superiority to the other for clinical purposes.
Now, I'll also briefly mention that there's another parameter called the Symptom Sensitivity Index, or SSI. And this is very similar to the Symptom Index with a slightly different formula, but this is not really often used nowadays, and it's not reported in this data.
So now that we've done an overview of the study, we can start looking at the data a little bit closer. On the following page, we see a lot of the same numbers as on the first page with a few additional parameters. We can see the total time of the study is 96 hours. Now, protocols from lab to lab vary, so the typical Bravo duration can range anywhere from 48 to 96 hours.
Now, it's important to keep in mind that esophageal acid exposure varies from day to day, so increasing the duration of the study increases our sensitivity for capturing pathological acid reflux. Certain foods like carbonated beverages, wines, or citrus foods can be very acidic and can create variation from day to day. Coca-Cola, for example, has a pH of 2.5, which can artifactually increase reflux episodes recorded on the probe. For this reason, it's important to review the patient's diary and correlate the timing of reflux episodes with what the patient was eating at the time.
So we can see on this 96-hour study that the analysis time was 87 hours and 40 minutes. And the reason for this discrepancy is anytime the probe becomes out of range of the receiver, it won't record the data. We can also see this broken down into upright and supine times. We can also see on this page the total number of reflux episodes at 172, and this is further broken down by upright and supine reflux episodes. And keeping in line with our preliminary diagnosis that most of these reflux episodes were when the patient was upright, we can see that 149 occurred upright and 24 supine. So now let's look at each individual day of the study. On day 1 of the study, we see that in this patient's particular case, for all 24 hours of the study, the patient was upright.
It's important to note that the self-reported data, such as whether the patient is upright or supine, when the patient eats meals, when the patient takes medications, and when they have symptoms, is only as good as the patient logs it. So it's important to keep in mind when analyzing the data on the Bravo probe to also correlate this with the data in the patient's diary.
We see that the total acid exposure time was high at 7.8%. It had 53 reflux episodes, with the longest episode lasting 31 minutes. We also get a DeMeester score on each day. So if we're looking at this day in isolation, this one day alone would be considered pathological acid reflux. On day 2 of the study, we see that the patient was upright for 11 hours and supine for 12 hours. So now we have this column indicating additional data points. We again see an elevated acid exposure time in both upright and supine positions. The majority of these reflux episodes occurred when the patient was upright, and the longest reflux episode was 16.9 minutes that occurred when the patient was upright. On this day as well, we get an elevated DeMeester score indicating pathological acid reflux. On day 3 of the study, we see a similar picture, elevated acid exposure times in both upright and supine positions, with most of the reflux episodes occurring when the patient was upright. On this day as well, we have an elevated DeMeester score indicating pathological acid reflux. Now on day 4 of this study, we see a little bit of a different picture. Unlike the previous 3 days, the acid exposure time on day 4 is actually completely normal. It's normal in the upright position, but slightly elevated in the supine positions. We still see that most reflux episodes occur when the patient is upright. And the DeMeester score falls slightly below our threshold of 14.7. So on this day alone, this would be considered a normal day. So because of the discrepancy from day to day, it's really important to look at the study as a whole. If we look at some of the graphical representations here, we can see some of these acid reflux episodes. Now, each box here represents a spike in acid reflux. Now, you won't see a box for every single spike because otherwise the graph would just get too busy. Now, we see here the patient has a meal and doesn't have any reflux episodes during the meal, but continues to have periodic spikes after the meal, which also preceded the meal. Further down the study here, we see some additional spikes in acid reflux, and a lot of these are correlated with the patient's symptoms. So here the patient reported a symptom, and it was correlated with this spike in acid reflux. Here we see a much more prominent reflux episode, and the patient reported symptoms during these episodes as well. Now here we see a gap in the data, and this is due to the probe losing signal with the receiver. We have to keep in mind these artifacts when interpreting the data. So now that we've looked at each individual day and the pH tracing for the study, we can put everything together and develop a diagnosis. So on the majority of the days, this patient had pathological acid reflux that was mostly related to upright positioning and was not related to meals. This patient's symptoms are very strongly correlated with reflux episodes as indicated by the SI and the SAP. This would be an appropriate patient to start on a PPI. Now, on the following examples, we're not going to spend as much time analyzing each individual day of the study. I just want to highlight some important points that you may run across as you're analyzing probes. So as we do with every study, the initial thing we want to do is look at the overall summary tracing and get a preliminary diagnosis. So this is a 2-day study, and we can see on the first day, pretty normal study. Maybe only just one event of reflux here, another event here, and then on day 2 of the study, we see lots of acid reflux. Our overall acid exposure time is elevated, which is indicated by our acid exposure percentage time as well as our DeMeester score. If we look at day 1 of the study, we see just one reflux episode recorded with an acid exposure percentage time of 0%. And looking at this alone gives us a negative DeMeester score. Day 2 of the study, though, we see a very different picture. Acid exposure time is 15.4%. And our DeMeester score is very elevated. We can see just how much variability there can be from one day to another. So day-to-day variability in esophageal acid exposure exists due to numerous factors. And therefore, it's not surprising that data can be discordant from supporting a diagnosis when examining each individual day at a time. Even when the cumulative data for the study suggests a normal amount of acid exposure, patients with a single day of pathological acid reflux exposure may be considered to have an earlier stage of reflux disease. So therefore, if patients have an abnormal composite pH on any day of the study, they should be considered to have increased esophageal acid exposure and pathological acid reflux. This is another reason why it's critical to examine each individual day of the study and not simply look at the study summary. This next case highlights a patient with predominantly nocturnal reflux. So if we look at the study summary, we can see a few episodes of acid reflux here that occur during the daytime, this very prolonged period of acid reflux that appears to be at night, a few more reflux episodes during the day, and then on the last night of the study, it appears another prolonged episode of reflux followed by additional reflux episodes. The total acid exposure time is abnormal, but it's predominantly in this supine position. If we look at day 1 of the study, the patient was supine for 7 hours and 36 minutes, and 6 hours and 26 minutes of this was recorded. The total acid exposure time on day 1 is actually completely normal for both upright and supine positions, with a negative DeMeester score. Day 2 of the study is where we saw that prolonged period of acid exposure on the summary tracing. So the total acid exposure time is abnormal, and it's predominantly in the supine position, with the longest reflux episode being 63 minutes. And our DeMeester score is very positive, unsurprisingly, on day 2. On day 3 of the study, normal acid exposure time except very abnormal in the supine position. And this gives us a positive DeMeester score as well. And finally, on the 4th day of the study, abnormal amount of acid exposure time, and again, predominantly in the supine positions, with a DeMeester score suggestive of acid reflux disease. Now, if we look at the longest reflux episode, which was recorded at 63 minutes on this study, we can see it here. So just to get a reference point here, each one of these notches represents 1 hour of time. And each of these boxes represents a reflux episode. So we have here over an hour of prolonged acid exposure with a brief period of somewhat normalization of the pH in the esophagus, followed again by prolonged acid exposure, and again a brief period of normalization followed by additional acid exposure. So the 63 minutes in the study is measuring this duration here. But aside from these brief blips in near normalization, this is more or less a over 2-hour period of prolonged acid exposure. So it's no surprise that the total acid exposure time on this day is going to be positive. So why is it important to recognize GERD that's positional? Well, because we can target our therapy towards this kind of GERD specifically. We can optimize acid suppression medication and ensure that the patient is taking the right dose at the right timing and the right frequency. We can recommend that patients sleep with the head of the bed elevated, and we typically like this to be at least 30 degrees or so, and this can be accomplished with a wedge pillow. We can ask patients to avoid alcohol, caffeine, spicy foods, or any other trigger foods, especially before bedtime. And we can ask patients not to lay in the recumbent position for at least 3 hours after meals, and this may be longer for patients that have gastroparesis. In this next example, we'll see early probe detachment, which is fairly common and is important to identify because if we fail to identify it, it can lead to false positive results. So on this tracing here, we see multiple transient episodes of reflux, and then towards the end of this study, we see this very prolonged period of acid exposure. So to orient you to time, from here to here is 12 hours. So this period of prolonged acid exposure is probably at least 8 hours or so. Acid reflux episodes are transient. So a sustained period of acidic pH is often indicative of early detachment of the pH probe falling into the stomach. Now, once the capsule exits the stomach into the duodenum, the pH returns to about 7, indicating that the capsule is now coming into contact with bile. And as a result, we need to factor out this data when considering a diagnosis. Here's another example of early probe detachment. We see multiple acid exposure events, and then towards the end of the study, we see this prolonged period of acid exposure. Unsurprisingly, this has significantly increased our acid exposure percentage time, as well as our DeMeester score. Now, if we take a closer look at this prolonged period of acid exposure, we can see this little blip in the data. Now, sometimes this is correlated with a meal, which briefly increases the pH of the stomach. We don't have the luxury of seeing what happened after this data point, but because this period of acid exposure was inconsistent with the rest of the study, as well as the fact that this reflux episode lasted as long as it did, we can say with a fairly high degree of confidence that this is an early probe detachment. It's important to note that the software does not recognize early probe detachment, so this prolonged period of acid exposure will artificially inflate the acid exposure percentage time and raise our DeMeester score, possibly giving a false result if we don't account for this. So what I'd probably do in this case is look at each individual day of the study, factoring out this last day, and if the first couple days of the study are consistent with reflux, which based on the summary it appears to be, then we can make a diagnosis based on that. In this next case, we'll look at a patient with reflux hypersensitivity. So first we'll look at our summary of the data. So we see a few spikes of acid reflux, but overall it's not that bad. It does not appear to be related to position or a meal. Patient does report multiple symptoms in the first day of the study, and it appears that a lot of these symptoms are correlated with reflux episodes. So if we look at our acid exposure summary, it's completely normal. However, if we look at our symptom association summary, we see a symptom index of 50% for belching, which reaches our significance, as well as a very high SAP for both heartburn and belching. So what do we do when a study shows a high SI or SAP, but a normal amount of esophageal acid exposure? In other words, the patient has a normal amount of reflux, but they're very sensitive to the reflux episodes that they have. Well, this is consistent with reflux hypersensitivity. So here's the Rome 4 criteria for reflux hypersensitivity, and I just want to highlight this part right here, that symptoms have to be triggered by reflux events despite a normal amount of acid exposure. So we can think about this by putting patients with symptoms of GERD on empiric acid suppressant medications. If we do an upper endoscopy and there's no endoscopic finding of reflux, such as esophagitis or peptic strictures, then we can consider esophageal pH monitoring. If there's a normal amount of acid exposure, but their symptoms are well correlated with reflux events, then this is consistent with reflux hypersensitivity. If they have a normal amount of acid exposure and symptoms are poorly related to reflux events, then this is more consistent with functional reflux. So in short, hypersensitivity syndromes are attributable to reflux events, whereas functional syndromes are not.